Hey, I'm making my own way, but I stumble and I falter every day. But I love my baby now. But I love my baby, I'm still learning how. Hey, 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 I'm okay.
Hello, and welcome to another installment of Pathways to Parenting Success. I'm your host, Dr. Jan Hittleman, Director of Boulder Psychological Services, and we have a wonderful panel tonight to discuss a really important topic. The topic is ADHD, or is it? And so we're going to be discussing ADHD in terms of diagnosis, helping all of you in the audience understand a little bit more about this disorder and some of the confusion that tends to take place in terms of proper diagnosis for attention deficit hyperactivity disorder. Before we get started, I'd like to thank our sponsors, the Boulder Valley School District, the Boulder County Healthy Youth Alliance, Centennial Peaks Hospital, the Hope Coalition, the Boulder Counseling Cooperative, the Parent Engagement Network, and the Camera, the Daily Camera, as well as Channel 22. We appreciate their support. Without their help, we could not provide you with this free ongoing series. And we're going to start our presentation tonight with a short video from the National Institute of Mental Health, just to give you a little bit more background in terms of ADHD and some general information.
ADHD, Attention Deficit Hyperactivity Disorder, is one of the most common mental disorders that develop in children. According to Dr. Ben Vitiello of the National Institute of Mental Health, nearly 5% of all school-age children may have the condition.
The main symptoms of attention deficit disorder are hyperactivity, which means a motor activity that is not really aimed at specific tasks and it is developmentally inappropriate, level of impulsiveness that are also considered to be abnormal for the developmental stage of a child, and sometimes also combined with inattention, inability to concentrate on tasks long enough in order to complete the task that a child of a certain age should be able to do.
But Dr. Vitiello points out the presence of symptoms does not necessarily mean a child has ADHD. Clinical evaluation needs to be made of a child showing behavioral issues that create problems at school, at home, or in social settings. Stimulant medications such as Adderall or Ritalin have been proven to be highly effective in controlling ADHD symptoms. But oftentimes the question is asked, how can stimulants be used to treat hyperactive behavior?
They are correctly identified as stimulants because they stimulate the brain to pay attention, they stimulate the part of the brain that pertain to executive functioning in particular, so ability to efficiently complete tasks. As the child performs more efficiently and is more focused, it may look that he is calm. Indeed, he is not just calm, he's just engaged in a task in a much more efficient and focused way.
In addition to advances in behavioral study of ADHD, remarkable strides in technology have given investigators an even clearer picture of the brain at work.
There have been really huge advances in looking at the brains in kids with ADHD. The biggest single change has been the advent, the arrival of magnetic resonance imaging, because that's safe. It doesn't involve any radiation, so we can scan children as they grow up, and we can scan them repeatedly, because the best way to capture a developmental problem like ADHD is to look at the same child over time as they're growing up.
Of particular interest in recent research is charting the growth of the brain's cortex in children with ADHD.
And one thing that we find, that the main finding, is that kids with ADHD show basically the same overall pattern of brain development or cortical development. It's just that everything in kids with ADHD tends to be a bit slower. It's all a bit delayed. So the parts of the brain where this delay in maturation is most pronounced is at the front. there are the parts of the brain that are very important for the control of action and attention. And that gives us all sorts of new targets to look at for potential treatments in ADHD, things that we didn't think of looking at before. So for example, if you find that the brain development kids with ADHD is a bit delayed, that might suggest that we should start looking at the cellular mechanisms, the basics of why that might be the case. And that also then leads to thinking about all sorts of genes which might regulate the timing of brain development and how they might be a bit different in kids with ADHD. All of this sort of work, working from the basic brain science and the basic genetics of ADHD, I think it gives us very good leads into future potential novel treatments for ADHD.
To find out more about ADHD and information about locating mental health services in your area, go to nimh.nih.gov.
Keep in mind that we would like to include you in our conversation tonight as well. The folks in our live audience here have index cards, so if you have any questions for our panel as we proceed, please jot those down, and we'd be happy to try to answer those questions. And for those of you watching at home, you can join the conversation as well by going to boulderpsychologicalservices.com and just click on the Submit Questions icon, and that will bring your questions right to us, and we'd love to have your involvement in this conversation this evening. I'd like now to introduce our three panelists that are joining me tonight for this important discussion. First, we have Anna Stewart. Anna has supported families for over a decade personally and professionally. She has facilitated a parent ADHD support group for over 5 years and provides support, information, and resources to families in the Boulder Valley School District through her role as parent liaison. Anna is also the mother of a son with ADHD and a daughter with cognitive disabilities. In addition, Anna is a professional writer and works closely with systems and families, helping youth develop self-advocacy skills so that they can determine their own futures. Welcome, Anna.
Thank you.
I'm also pleased to introduce Linda Kane. Linda Kane has worked with adolescents and young adults for over 30 years as an educational and therapeutic consultant. She helps families identify appropriate resources such as therapeutic options, specialty boarding schools, and rehabilitation programs to support student success. She specializes in learning disabilities, emotional, behavioral, mental health, and drug and alcohol issues. Finally, our third panelist is Dr. Lee Johnston. Dr. Johnston is a psychiatrist and psychoanalyst for children, adolescents, and adults. He has been in private practice since 1983, first in Seattle for 17 years, and now in Boulder for the last 10 years. He teaches at the Denver Institute for Psychoanalysis and is clinical faculty at the Department of Psychiatry, University of Colorado Health Sciences in Denver. Welcome to our panelists tonight. We're going to start by hearing from our panelists in terms of this topic, the concerns about ADHD being properly diagnosed. Who would like to start us off? Lee.
Yeah, I want to make specific some terms and to take the term ADHD and put it into perspective. ADHD is a term really that dates back 6 decades practically, that was originally intended to be a set of research criteria. Basically, the symptoms had to be within 3 areas, as was specified on the film: inattention, impulsivity, hyperactivity. The symptoms had to cause significant impairment, so you would see academic failure or behavioral problems. And most importantly, it was a diagnosis of exclusion. In other words, it was intended to try to capture a set of symptoms that were thought to be developmental in nature, not caused by anything else. Now, as the years have gone by with research like was indicated, particularly magnetic resonance imagery, we know these symptoms to be subsumed under a larger category we call executive function. Executive function is the area of the brain, prefrontal cortex. It extends all the way back through the rest of the brain and all the various other areas of cognitive processing. So it's basically executing the function of the brain into various kinds of expression and behavior. So when you look at executive function, you're really trying to look at the way that it executes other cognitive processes in the brain. For example, auditory processing, visual processing, language processing, both written and verbal, encoding of memory and retrieval of memory. Also, the fact that it can help modulate emotions. Now, in trying to give you an idea of what it means to have executive function, 5-year-olds can typically sustain attention in order to manipulate about 1 to 2 pieces of information, cognitive processing. When you go to a 10-year-old can sustain attention to manipulate about 3 pieces of information. And naturally, a 14-year-old can do about 4 pieces of cognitive processing or information processing. So it is a developmental process. And in order to give you an idea of both what executive function does, and then to talk to you about some of the symptoms, I then will talk to you about what can cause these symptoms. So can I have a few more minutes?
Definitely,
Okay.
please.
First of all, when executive function is operating in the central way that it does is sustaining attention, it helps to organize, multitask, problem solve, hold attention across various patterns and sequences, to evaluate past actions and future possibilities, to initiate action, to sustain the action of an endeavor so that you can complete the endeavor, to inhibit impulsivity, and to orchestrate and coordinate choices. Now, as you might expect, those areas will show up symptomatically if there's an executive function disorder. So I'm going to give you a list of symptoms that will sound very similar to what I just said. First of all, someone with executive function symptoms would have inability to hold multiple pieces of information in mind while solving a problem. For example, a math problem. Would not be able to hold a set of instructions in mind, like a teacher telling a student exactly how to proceed with an assignment, or to accomplishing a sequence like a list of chores. There's also a limited ability to plan and organize, prioritize. There's a lot of struggle with executive function issues to communicate details in an organized and sequential manner. There's also a limited capacity to evaluate and to reflect upon multiple elements when you're trying to choose and initiate or change a course of action. Executive function symptoms show up in terms of impulsivity, where there's action taken without consideration of much judgment or the options. There's a high degree of distractibility with executive function symptoms. There'll be the inability to sustain attention across emotional parameters so that you can actually modulate emotion. So there's often emotional reactivity, outbursts. There's difficulty in engaging in group dynamics, particularly if the group has a lot of stimulation in it. Then there's impaired ability to actually encode memory or to retrieve memory. Now, when you try to list the kinds of things that can cause executive function symptoms, the list is enormous, really. ADHD is just one item of that list. And I'll say a few more things about ADHD, but to give you an idea of how extensive the list is, for example, brain trauma. Any concussion has the potential for causing executive function issues, particularly acute brain trauma. Infectious disease, whether at an early age and manifesting later, or a chronic infectious condition like meningitis. Cardiovascular events, for example, stroke. Mild cognitive impairment of aging. Medications, in fact, it's given the name chemo brain. Cancer chemotherapy will cause executive function issues. Of course, drugs off the street, like marijuana, has a huge database that documents executive function issues caused by marijuana. Mood disorders, depression, bipolar, anxiety disorders, that's OCD or post-traumatic stress disorders, congenital disorders, birth trauma. There are many, many other medical causes. Fatigue, for example, that's caused by sleep disorders, or fatigue related to anemia. Of course, stress. Any of us have felt enough stress that it's impaired our executive function. It's associated with developmental disorders like Asperger's. It's associated with many learning disabilities like dyslexia. And finally, ADHD. Just to clarify a little bit more about ADHD. ADHD was noticed as early as 1937 when it was first treated with stimulants. It got extremely controversial in the 1960s when stimulants were being used much more in the population. But basically, we understand now that ADHD is a listing of these executive function symptoms, which is a much larger category of these symptoms. And what distinguishes ADHD is not only the degree of impairment, but the fact that it's not supposed to be caused by anything else on this list. It's a diagnosis of exclusion. It was intended to be a listing of these symptoms as if we were capturing a developmental anomaly. So I want that to be one of the main sort of themes that we try to research and talk about when this comes up about misdiagnosis of ADHD.
And if we could look at slide 1, Lisa. Slide 1 kind of relates to what Dr. Johnston was just talking about. And, you know, the point here, which is important, is that there are a lot of other issues that can cause these same kinds of problems. So if you look at this slide, you'll see that we have things like Dr. Johnston just mentioned, and I would really point you to those first 2 or 3 at the top of the list. And I mentioned this, and those include things like depression, oppositional defiant disorder, anxiety disorder, learning disabilities. I mention this because in my clinical experience over the years, these are very commonly misdiagnosed as ADHD. And certainly with something like an anxiety disorder, for example, the last thing we would want to give to that person is stimulant medication. And so it's critically important in terms of our treatment plan to first be clear about the diagnosis. And if you look at slide 2, you'll see that a lot of these things are mistaken for ADHD, and that comorbidity, which basically means there's more than one disorder in play, is the rule, not the exception for ADHD. And as you can see from slide 2, a significant percentage, from 58 to 87%, depending on which study you look at, children diagnosed with ADHD do have a comorbid disorder. And the point here is that we see situations where there are certainly kids that do have ADHD as well as other diagnostic issues. But unfortunately, there are many kids that are diagnosed with ADHD when some of these other issues are missed. And that's critical in terms of problems for those children moving through school, dealing with social situations, responding to parental requests, etc. And you can see from the list that the most common comorbid disorder with ADHD is oppositional defiant disorder. And those of you parents who have children with ADHD, I'm certain understand this, that it's often extremely challenging. And sometimes it relates to that impulsivity factor. We also see a significant number of kids with learning disabilities, in addition to ADHD, as well as anxiety disorders and mood disorders and substance abuse issues, as Dr. Johnston pointed out. Let's hear from some of our other panelists in terms of some of their thoughts around ADHD and diagnostic concerns. I'm guessing, Linda, in the work that you do as an educational consultant, this may be an issue that you've seen happen with families.
Yes, I actually see it more often than not. ADHD does seem to be more of a catch-all diagnosis. It seems to be something that sometimes I think it's diagnosed by the parents, sometimes it's diagnosed by a teacher, sometimes a doctor may listen to what the parent has to say and then diagnose the child, but I think there needs to be a lot more than just looking at a current situation. You know, I often get people in that say, my child isn't doing well academically, you know, they have ADHD. And when we start to dig into this more, get some formalized assessing done, formal evaluations, some clinical evaluations done, looking back over the history of things of the child, many times, you know, it isn't ADHD, it's a learning disability. And I know sometimes people struggle with, well, what's actually the difference between a learning disability and ADHD? And I think a really, an easy way to understand it is, think of walking into a room where you're going to be doing some sort of a task, and there's an overhead light on, and there's lots of lamps around the room illuminating it. And if you have a learning disability, it's like turning off one or two of the lamps. So there's areas that you might struggle in to see things or to be able to do that work that you need to be doing in that room. If you think of ADHD, it's like turning off the overhead light. So it really affects, it's more pervasive. It affects all the cognitive functioning. So, you know, I think going over such things as a thorough history, looking for things, other things that could be the cause. You know, there could be medical issues. It could be something else that could be diagnosed, like trauma. I think talking to other people, you know, have the teachers seen a different recently? Look at what's going on in the child's life. But I think diagnosing is something that needs to be done thoughtfully and completely. And I think one of the more important things is getting a formalized evaluation, academic and cognitive testing, emotional testing, something called a psychoed eval. I don't know if you're going to talk about that, Jan. I know Jan does those. Other professionals do those. I think that's really important when you're throwing the term ADHD out.
Yeah, and you know, I brought in, hopefully we'll have time in a little bit, I brought in 3 clinical case studies to share with you of children that all appeared to have ADHD, but I think you'll find it interesting in terms of the testing and the results and how they really were very unique, each unto themselves. So we'll talk about that a little later on. Thank you, Linda.
Yeah.
And Anna, I'm interested to hear from you as well. I know you've worked for many years with a large number of families of children that have had all kinds of different learning challenges. What's your experience been in terms of this topic?
Yeah, I have worked with a lot of different families, and there's a couple of things that have come up, and one is sort of that developmental piece, that things change over time. The other piece is the medication. In our ADHD support group, that's always a point of conversation, and parents will say, I've tried meds and they don't work, and which is always a red flag for me, like, well, maybe there needs to be a little more investigation into the process. And then they'll come back, 6 months later and say, hey, we just found out it was sleep apnea. Yeah. And that our kid hasn't slept, and he's 16 and hasn't slept in ages. So I think a lot of what happens is that there's pediatricians making diagnoses, and sometimes they don't gather as much information as other clinical settings, like I think you guys do, to really bring together all of the pieces in a family story to figure that out. And I think it's true. It's sort of a catch-all. It's an accepted thing. It's sort of normed now that it's okay to have ADHD. It doesn't have a lot of stigma to it. So the kids as well as the parents, it's like, oh, let me grab onto that. I know where I am. I know what to do with it. Versus some of these other pieces, especially if you start dealing with anxiety disorders and mood disorders, OCD, some of these other areas are scarier for parents to be looking at. And they bring up a lot more fears and concerns, and so I think they're less likely to go there because they're just it's a lot more uncharted territory than the term ADHD. And I know my son, it's like, yeah, I got ADHD, and so do all my friends. It's sort of like we're part of the club, and we compare which meds we like, and so that changes the equation, I think, a little bit in a way that is missing a lot of these kids, because I see that too, that there's a lot of families that aren't looking at the whole picture. And I actually just found this study that came out just this last week through the National Center on Birth Defects and Developmental Disabilities and through the Center for Disease Control and Prevention, and they did a study with 10,000 students in 4 different districts over a couple different states, and found that they were both over-medicated and underdiagnosed, is what they came up with, that there were close to 10% of kids that did meet criteria for ADHD that did not have that diagnosis and therefore did not have any treatment. And then of the kids that did have that diagnosis and were on medication, depending on the county that they were reviewing, there was anywhere between 30 and 39% of the kids that did not meet the criteria that were currently on ADHD medication. So there was a lot of disconnect there. This was more about the diagnosis rather than, well, what's that look like in schools and what's that look like at home, which is probably what you guys are interested in. And as a parent liaison, I know that it's what do we do with this, regardless of it. But I think this is pretty interesting that there's some brand new studies really coming out that say we got to be looking at executive functioning and all these other potential diagnoses and issues that can be coming into play. And they're just not on people's radar. So I think they sometimes forget to give information to their doctors too. They don't think, oh, I forgot to tell you that my son was born premature and was in the neonatal intensive care unit for 3 months and has always been a little dysregulated. And they forget that, and that maybe that's a lot more important than anyone really realized. But part of the problem, I think, it's just not on our radar as a society right now.
The other thing I'm curious if you have an opinion on it, Anna, and this is something that I've observed from time to time, is that in the school system, a diagnosis of ADHD often results in additional services. And so I wonder if a parent, very well-intentioned, knowing that their child is not functioning well in the classroom, needs extra help, kind of sees that as a means to an end. And if it's quickly diagnosed, and I've seen this too, where a pediatrician, very well-intentioned, will just base the diagnosis based on the symptoms alone, without looking deeper. And as we just discussed, there could be a lot of reasons for those symptoms. It puts that child on a track that may not be the correct track. Is that a fair assumption?
Yeah, I mean, the thing though with getting a diagnosis, it does not equate services in the school district. So a diagnosis doesn't equal anything. You still have to show and work with the school team to show how that disability or that diagnosis, which is, if you're calling it into special ed, it has to be considered a disability, that it significantly impacts the student's ability to access education. Mm-hmm. So I think a lot of our kids with ADHD, and you guys probably can start nodding your heads, do not get on into special education because their symptomology doesn't look serious enough. Mm-hmm. And then there's the other side of that, which is it's way too easy then to see, well, if you just medicated him or her, then we could do our job and they could learn here. And that's a tricky piece sometimes when you have that little bit of another place for disconnect is that medication is sort of the go-to treatment for ADHD. And if that's a family's, either they're trying it and it's not working, or they're not interested in trying it because their child is young or have their personal reasons, which are totally their reasons to look at, the school might say, well, if they're, our job can be a lot easier if you medicate them. And then you set up a little bit of a tug of war. And the parents may have tried medication, it's not working, but everyone's still caught in the ADHD diagnosis instead of stepping back and saying, maybe we need to look at this and see what other pieces are in play and how can we support that executive functioning piece, which I think is a really big piece because it's a lot of our kids in the district to have executive functioning issues because all these other issues that, Asperger's and TBIs, traumatic brain injuries we have a lot of kids with those concerns. And so learning how to work with executive functioning, I think, is a key place to sort of reframe this conversation. Mm-hmm. And I really appreciate that Lee brought that in right at the beginning because that gives you sort of a more practical, specific approach to take to look at, okay, the executive functioning is here. Let's look at understanding a little bit better, and then look at a treatment plan that is maybe not so medication based.
Right. And I'm going to ask Dr. Johnston in a little bit to talk more about that in terms of alternative approaches
Yeah.
besides medication for executive function deficits. So I'm looking forward to that as well. I'm thinking now might be a good time for us to talk about these clinical case studies that I mentioned earlier. I'm going to try to go through them fairly quickly. I want to leave plenty of time for your questions and for our panelists. But let's do that. And if we could start with slide 3. And it would be good if I could see those, Lisa. I'm going to tell you about this first boy. We're going to call him Tom. And at the time that he was evaluated, he was 10 years old and in 5th grade. And when the parents came to me, they discussed in their words that Tom sometimes seems not there, unresponsive, and almost dazed. His schoolwork suffered from lack of focus and interest, despite apparently high intelligence. And as early as kindergarten, there were concerns regarding focusing. One of the things that we look for the diagnosis is the symptoms should be there by age 7. Not always the case, but that's part of the diagnostic criteria. So here's a boy who really seemed to fit it. And when we look at, and oftentimes the way that this is determined, it could be a pediatrician just making the diagnosis based on the information I just shared with you, believe it or not. Some folks very appropriately go deeper, and they'll give a survey form, which is very common. And this is an example of a survey form, the Behavioral Assessment System for Children, or BASC-2. And on that form, we can see that Tom's responses, his own responses, indicated some attitudes about school, but also attention problems and hyperactivity. And then if we go to the next slide, you'll see similarly that his parents also indicated concerns around attention issues, as well as some other behavioral concerns, aggression, conduct issues, social issues, anger issues, some bullying concerns as well. And the next slide. And even Tom's teacher had concerns about attention problems and hyperactivity, also executive functioning, as well as some learning issues and study skill issues. And so looking at all of this information, it's ADHD, right? I mean, everyone's saying it. He has attention concentration problems. He's experiencing it. The teacher is saying it. The parents are saying it. Let's look a little bit further in terms of some of the testing that was done. Next slide. Tom was given the Wechsler Intelligence Scale for Children, which is an intelligence battery. And more important than the full-scale IQ, we really look at those subtest scores. And I'm not going to go into that level of detail tonight, but even if you look at the composite scores on that chart, you will see that he really was pretty strong in most areas. The area that he had relative weakness was what we call processing speed, which basically means how quickly he could get things done in a timed situation compared to other kids his age. The area that usually we see issues around ADHD is that working memory index. And interestingly for Tom, that working memory index was quite strong. This looks at short-term auditory memory, as well as some other functions that involve primarily auditory memory skills. Next slide. We also gave Tom some achievement testing and to look at his academic abilities. And again, when we look at these, let me just find mine here. And I would suggest to make it simple, just look down the column that says percentile rank. And you can see that in most areas, Tom was pretty solid. He did have some issues around written expression problems. If you look at sentence composition, essay composition, they were fairly low relative to his intelligence, relative to his other academic areas. Numerical operations was relatively low as well. And then again, processing speed came up again in the bottom category, which is math fluency. Fluency is just a fancy word for speed, and that would be doing those 1-minute kind of math tasks where he struggled as well. Next slide. Then we looked further. We gave him a test that looked specifically at attention. The one that I like to use is the test of variables of attention, or Tova, but there are other tests like this out there that are also good. And on this test, which is a very, very challenging test, it indicated that Tom really did not have an attention problem because his score was actually quite good. We looked for a score below minus 1.80, and his score was actually significantly above that at 0.39. The analysis did show that he had some impulsivity errors, but they were well within the normal range for a child of his age. And we also gave, and this is something that's important, earlier Linda mentioned the psychoed eval, and I know there's a lot of terminology that we're throwing around here. I apologize for that. But I want to make the point that oftentimes we do not give personality testing as well. It's a mistake, in my opinion, because the personality testing is where we really could look at things like depression, anxiety, etc. And in this case, the personality testing really gave us clues as to what was going on. This young man often escaped into fantasy, which was negatively impacting his focus on tasks at hand. He also would identify with heroic figures from combat video games. He was very into video games. And he would often fantasize about these characters from books and movies. And he really had trouble dealing with stress and worry, and so he would utilize escape into fantasy whenever he felt stressed. And this was actually what was playing out in school. It was not an attention problem, it was more of an emotional response to challenges where he would just kind of check out. He described himself as being very absent-minded, and he was right. And that's different than ADHD. There were other indications, too, that he had some resentment towards school and teachers, as we saw in his survey form. And so part of his response to school was to avoid what he could and minimize his responsibilities in school. And using these avoidance and escape strategies, it started to really affect his grades. And so for Tom, what we did is we came up with some behavioral programs to motivate him more in school, and also to let him know that the jig is up, that he has great skills. And the other thing that's interesting to consider about Tom is that his academic skills are fairly strong. We expect to see significant weaknesses if ADHD is really at play, especially come 5th grade. Let's do one more. Let's talk about Robert, who is also age 10. And on the first slide here, we can see Robert's responses to the Basque form that he filled out. And here as well, we see concerns around attention, hyperactivity, attitude towards school, and then we also see anxiety. Locus of control is a fancy term for I feel like there's nothing I can do to change my situation, some interpersonal problems, and some other issues. Next slide. Robert's parents also filled out the form. Again, they had concerns around attention as well. Anxiety came up again, as well as some other emotional concerns, withdrawal, emotional self-control, and again, executive functioning issues. So we're still not sure. We see some ADHD concerns. Next slide. We provided him, in this case, the parents did not want the teacher to fill out the form, so we didn't have that information. The testing that we did with him with the intelligence battery starts to show a different pattern than we saw with the other child that we discussed. If we look at working memory, it was quite low. It was at the 9th percentile. And this is a boy who's very bright. His verbal and performance composite scores were in the average and high average range, with low average working memory and borderline processing speed, which really brought down that overall IQ. Next slide. And when we looked at his achievement scores, we found some difficulties again in written expression and processing speed as well. But this case was very different. Let's look at his Tova. Next slide. When he took the Tova, which again looks very carefully at attention and impulsivity, it's a computerized test, his score was quite low, far below the threshold for kids with attention deficit. And so what was happening with Robert was very interesting. And one of the clues in this particular case was that he had severe anxiety issues that disappeared over the summer. And that tells us a lot. What was happening for Robert is Robert did have ADHD. He had it all his life. And school was a horrific, overwhelming experience for him. And as a result of that, he also developed significant anxiety symptoms because he felt completely overwhelmed. Remember the locus of control, not feeling like he can control his environment. And so for him, he did have ADHD, and as we talked about earlier, he had the comorbid disorder of anxiety as well. And so he really needed to be treated for both of those things. And again, if we just look at the feedback from teachers from the boy, these two boys would look very similar. I'm going to hold off on that third one so we can move away from the slides at this point because I want to get back to our panelists and also answer some of your questions. Any other comments before we move on to questions that anybody wants to make?
Yeah, I think it's really important. I know we've talked about how ADHD is overdiagnosed sometimes, but I think it's important to remember to look for ADHD if you have a child that's diagnosed with something else. So I think it can be overdiagnosed. I think it can also be forgotten. because we've talked about how comorbid it is or how co-occurring it is with other diagnoses and other problems that are going on.
Let's shift now to some questions from our audience. We actually got a couple of questions from a viewer in Lyons. And remember, the TV audience out there, we would love to hear from you. You just need to go to your computer, go to boulderpsychologicalservices.com, click on the Submit Questions icon, and we'll get your questions here for our panelists. A viewer from Lyons had a couple of questions for us. The first one, do girls present symptoms of ADHD differently than boys, and if so, how? Who's ready to take that on?
Typically, yes. Typically, girls tend to exhibit the symptoms of ADHD that have less hyperactivity involved with them, less physical, outward behaviors. They tend to be more withdrawn with their ADHD, but very distractible. They tend to have more issues with social things. It could be because as girls, they tend to be more social. Boys tend to not talk things out, perhaps a little bit younger, maybe just, slug it out if they have an issue with something and they're done with it, whereas girls will hold that emotional piece. But yeah, the things that I have seen is typically that they do show different symptomology.
Anyone else with thoughts about that? Gender differences?
I think it adds to the what you're saying, the underdiagnosis for girls and for women. I think there's a lot of women who have not been yet diagnosed with ADHD that probably actually have struggled with it their whole lives because it doesn't look the same, doesn't have that hyper part to it.
Mm-hmm.
So they stay under the radar and end up developing a lot of self-esteem issues because they feel like they don't know what's going on, they can't keep friends. So it's one of those underdiagnosed situations I think is often with girls.
And we do see that, when a child in kindergarten, first grade has the hyperactive, boy, it's pretty obvious, it's picked up pretty early on. But with that inattention, especially if it's a bright child, they can often compensate for that. And sometimes we don't see the issues come up in terms of school functioning till later in elementary school because they've been able to compensate effectively for a number of years, and then the ADHD, the inattentive type, really starts to interfere with their school functioning. Another question from our Alliance viewer, is the inability to regulate emotions a sign of ADHD? And if so, are medications the best way to help this situation, or are there other alternatives that might be more effective? And I know you had mentioned earlier, Anna, the idea of dysregulation being a factor. Lee, any thoughts on that? The inability to regulate emotion, is that a sign of ADHD?
Well, if you have just that symptom, you'd be so important to rule out all the many other things that can cause dysregulation of emotion. Mm-hmm. Certainly ADHD can have that symptom. I don't think I've ever seen that symptom in isolation so that you would think first to go to the ADHD diagnosis.
Mm-hmm. Other thoughts? A question from our live audience here. Do you have any thoughts or how all the different electronics in a child's life can cause inattentiveness and be misdiagnosed as ADHD? The other question that I hear a lot that I'd like to add for the panelists that relates to this is the seemingly impossible fact that a lot of kids that have ADHD have trouble concentrating in school, but put them in front of their favorite video game and they're focused for 8 hours at a time. That hyper-focus, sometimes it's referred to as. So again, the question is, any thoughts on how electronics may play into inattentiveness and be misdiagnosed as ADHD?
I'm sure we all have comments. I want to comment on the hyper-focus piece. Concentration and focus are often sort of isolated as a way of trying to talk about ADHD. It rarely is a very good parameter because the real problem is trying to sustain attention over multiple modalities. Computer games are a great example of this. It's very easy for someone with ADHD. In fact, they like being able to be tracked into one single monofocus and can be extremely focused in certain activities that, particularly if they're fed by the TV or media, it can be like a magnet. Because what really is a challenge to ADHD is sustaining attention over multitasking. I'll pass it on to Gwen.
Yeah, I often see kids who are definitely into the video games or the computer games or TV, particularly the video games. And actually, it's not surprising because kids with ADHD are easily distracted, they're thrill seekers, they are in the moment kind of people. And when you think about it, this is something that's meeting their need with their hands often. They're getting oral feedback, they're getting visual feedback, they're learning right away if they're successful or not successful. It gives them something to shoot for, a better score or something to figure out. And, games aren't built to really sustain a lot of attention on one area. The little figure's always moving or changing, or something's being thrown in the way, an obstacle that you have to solve. So actually, I often see kids with ADHD that can sustain attention on that, but not doing their math homework.
For sure. I think the other point, though, too, is that sometimes I think the video games can be a calming factor because it's an external system that has that immediate feedback. So used it as sort of a, I don't use it, I wouldn't use it so much as a reward, but a lot of kids do really well if they get some not TV time because the feedback isn't there, but a video game or a computer game, because there's a regulation that can happen because there's an external setup from all the things that Linda just said with the changeability, but it's immediate feedback and they know right where they are. So there's a certain comfort that a lot of kids find in that, and I've seen a lot of them do much better if they can have that before they try to do something like homework. It sort of gives them a way of feeding the I don't want to call it the dragon, but feeding the ADHD tiger a little bit with something that sort of can have some containment, and get to the next level. Okay, now you're done, and now it's time to go on to the next task. Because it's so stressful for so many kids with ADHD or these executive functioning issues to like you just said, to function at school. School can be really stressful, but I think it sometimes can be used as a calming agent. And it's not, if you're on it for 8 or 9 hours a day, that's a different thing. Then you're moving into, I think they do it though, partly because it's an addictive piece, because it provides that external regulation that they don't necessarily have intrinsically. And it has all the variables that they like to have going on. So I don't really see it as adding to the problem unless it becomes too prolonged use of it, but that it can be used as a way also that they feel good. They get to the next level and they're like, yeah, I had some success. And all day long, all I got told was you need to sit down and pay attention and do this and do that. And that if it's something they really like, I think it can be one of the strategies at the home front to use. Again, I don't like it as a reward so much because I think there's other kinds of rewards, but that's a personal choice in a family. So I think it's not I don't think it's the reason for ADHD. I think you guys would, you either have it or you don't.
And, we talked earlier, I'd love to get your thoughts on this, Dr. Johnston. We talked earlier about, are there alternative treatments for executive functioning issues? I'm wondering if you could speak to that briefly for us.
Well, there are basically three ways to approach, and if you're trying to outline them in a big sweep of summary, one is medications. There are 5 groups of medications, not just the one group stimulants, but there are 4 other groups. 2, there's always been the big category of coaching, compensating, accommodations. Just to simply know that you've got the diagnosis is huge because everyone can get much better attuned to what the issues actually are and where the child is with himself. The third area that's got double-blind research supporting it is computer training for working memory. It's called CogMed, and has been available since 2004 out of Sweden, and is in this country now. It's something that is well documented, and it's 5 weeks of computer training specifically aiming at working memory, which improves executive function and the symptoms of executive function, including ADHD. There is some data for neurofeedback. It's at a level of research that is still controversial. so I won't make comments about it particularly. Okay.
Thank you. Appreciate that. Another question from our audience here. Please describe oppositional defiant disorder as independent from ADHD. How are they different, oppositional defiant disorder and ADHD?
Oppositional defiant disorder is a question as to whether it deserves its own category diagnostically. Almost always you can find executive function issues that exist contemporaneously with oppositional defiant disorder. It's very interesting to watch how oppositional defiant disorder has its own developmental track. Kids who do not execute very well across groups of play or in school will try to control their environment. They don't make transitions well. They don't respond to instructions very well. It very quickly leads to lots of reactivity and oppositionalism. So it's very common that if ADHD or other executive function issues from whatever source don't get appropriately identified and recognized, and instead everyone is trying to engage a process of just simply disciplining a kid into particular kind of behaviors that are expected in the classroom, then the natural consequence often is an oppositionalism that gets starting to get diagnosed as such. And then it's sort of given its own label. And if things go far enough, it leads to conduct disorders of various kinds.
And I would think it would be problematic to put a child who's really oppositional defiant on stimulant medication. That sounds like a bad idea.
Well, depending. You know, if it really requires a lot of scrutiny about what's going on at that time in the family and in respect to the executive function issues. And
especially if both are going on, right, when you have
Right.
that comorbid disorder.
right.
Another question from our TV audience here. If a child is placed on a BVSD program that provides assistance and labeled with a disability, could this affect their ability to be accepted to college or career? I feel like that's a question for you, Anna.
I think what you're asking is if you're on an individualized education plan, an IEP, which is a service of special education, if that affects college. The quick answer is no. For one thing, IEPs don't go to college with you. But what can go to college with you to give you supports is what's called a 504. It's through the Americans with Disabilities Act, and that provides accommodations, no services and no modifications to the work that a professor would ask you to do. So a goal for a lot of high school students, especially if they've had some of these diagnoses early, is to work towards reducing their need for some of the services on an IEP and work more towards understanding their accommodations and being able to advocate for them, because that's what they're going to get in college. So any college that has any federal funding at all has to meet that. There's a few private colleges that really don't, but most programs have. Nowadays, there's some really great exceptional student services. They name them different things like that. CU's got them, Metro's got a great program, Front Range, where they'll help make sure that the accommodations you need to access the program is available to you. So it would be a discrimination to say that you couldn't go to college because you had some kind of disability, and that would be really wrong. So we want to make sure that our kids get there. The colleges can't do the modifications, and they don't deliver services. But some of them have, I think CU has tutors even that you can hook in with, and coaches you can meet with regularly to help say, hey, are you on track? Do you know what you're supposed to be doing? Kind of being that external executive functioning coach to you. So there's some really nice services out there in the college and universities now.
Thank you, Anna. We have just a few minutes left. I'm wondering if I should do that other clinical case study, or we can go to more questions.
Jan, I'd just like to add, too, that as far as having a child on a 504 or an IEP and then applying to college, actually what's really important is while the child is still home in grade school, middle school, high school, helping them understand what their needs are and what it is that helps them. And beyond that, helping them to learn to advocate for themselves. I think where I see kids get in trouble in college is where, you know, they're used to mom or one of the teachers or somebody else saying, you know, have you gone to the learning lab? You know, have you done this? And kind of, yeah, orchestrating their life for them. And then they go to college and they fall apart. And it's like, well, I'm not really sure what I mean, everybody's always kind of told me what I need and done it for me. And I really think that one of the biggest gifts we can give our kids with any kind of a special need is to help them understand and also to help them know what it is and know how to advocate. Great story around this was I worked with someone who did have ADHD, and through a series of events, he decided that the way he functioned the best in class was on one of these big bouncy balls. And he was real good about, you know, not disrupting class. So long story short, he went to college, he carried his ball with him, and he was so comfortable with that when he got out and he was applying for jobs, he virtually would say, you know, I have to tell you, in the interviews, I do really well, but not in a chair. I need my bouncy ball. So he was successful, he got a job, he was hired by a company, and he was there about 6 weeks, and other people in the office started saying, you know, I need a bouncy ball too. And interestingly enough, they found out that their productivity in the office went up because, you know, people either came forward at that point or perhaps they didn't realize, and then they started to realize their own needs. But he made it that far because he understood what he needed and he was able to advocate for himself. So
And normalize it.
normalized. It wasn't a big deal. It was like saying, you know, I have brown hair, I have blue eyes.
I have to wear glasses.
I need a
otherwise I
bouncy
can't-
ball if I'm going
yeah.
to sit at an office desk most of the day.
Yeah, awesome.
That's great. Well, we're almost out of time. Other thoughts from the panelists?
I just wanted to add one thing from what Lee was saying earlier about working with our kids and piggybacking on you a little bit, is that having compassion for your children or for your or for yourselves if you're dealing with ADHD or something like that, and being able to kind of think what it must be like, 'cause going to that oppositional piece, you know, if a kid is really resisting, it's probably because they're really afraid or they're really hurting or there's something that's really off for them. And you know, many of us grew up in an era where there wasn't an understanding of that, and so we didn't necessarily come to parenting with the tools to know what to do with a kid that didn't just do what the teacher said and was successful like maybe we did. And that if a kid is, especially the little guys, you know, the elementary kids, you know, they're there, they want to be liked and they want to please, they want to do their little kid job. And when they're not, to me that's a big, when they can't, and you have to separate the can't from the won't. When they can't do it, to have compassion and think, God, it must be really hard to go every day and not have any idea what's going on because you don't have the working memory or the processing speeds, so you only get part of what a teacher's saying, and then you're supposed to do some work and you can't quite get it. To really make sure that we hold compassion for our kids and our coworkers or whoever, that might be a little bit harder for them, and instead of going, man, they're just not pulling their weight, or to remember that piece too. And then that's a good place to start that conversation about, here's the differences we've learned about how you learn, your neurodiversity, and how we can work with you and what kind of supports we're going to do, so that's not an excuse not to do your work, but we're going to give you the right tool set. But sometimes I have to remember that, even you know, with my adult friends with ADHD or my adult child now with ADHD, and say, whoa, sometimes this is that I'm up against is the ADHD and not my child. And then if I sometimes can remember to hold that compassion, it makes the parenting journey a little easier, and hopefully makes it a little easier for my son and for our other children to feel like there's nothing wrong with them. There's just a difference about them. So I just wanted to add that piece.
Very closely related to that is compassion for the parents of children who have not been diagnosed, or once they get diagnosed, there's so much genetic loading that goes along with executive function disorders. And when parents finally begin to understand what might be going on for their child, it makes a world of difference. So many times parents will be pathologized when a child is not behaving in a standard protocol way, and all the various other vicissitudes of that can surface right in the parent's lap at school districts and whatnot. So I think the diagnosis is something that's instrumental for both the kid and the parents.
Yes.
Time flies when you're having fun. I want to thank our great panelists, Dr. Lee Johnston, Linda Kane, Anna Stewart. Thank you so much for your time tonight. Our wonderful audience for their patience. I didn't see any ADHD symptoms tonight out there, so I just want to put that out there. We haven't tested you, but still. I also want to let you know that our next TV presentation will be on November 26th, and the topic is The Bully and the Bullied. Increase your understanding of this challenging phenomenon, learn what you can do to keep your child safe. It will be moderated by my colleague, Leisha Connors-Bauer from the Boulder County Healthy Youth Alliance. Thanks again to the Boulder Valley School District, Channel 22, and we'll look forward to seeing you next time.
Great.
Now the planet starts bowing down, and soon the growth returns to follow ground. But I know what's churning underneath the snow.